Here's our anatomical roadmap for rounds today. We're going top down. We'll start with hematuria and renal diseases, then move down to the ureters and bladder, hit prostatic diseases, cover true drop everything penile and scrotal emergencies, and finally, wrap up with the absolute genitourinary trauma guidelines.
All right, Section 1, Hematuria and Renal Diseases. Starting right at the top. So, the absolute cardinal symptom in urology, hematuria. If you see blood in the urine, whether it's gross or just microscopic, which we define as 3 or more red blood cells per high-power field, you literally have to do a complete urologic workup, no exceptions. It's a strict 3-step algorithm. Step 1, get a urinalysis and culture from a fresh, midstream catch. Oh, and if it's gross hematuria, you've got to add cytology. Step 2, the CT urogram. This is your go-to imaging, and it must be 3-phase, meaning without contrast, with contrast, and deleted images. Step 3 is cystoscopy. Look, imaging alone is going to miss tiny lesions and strictures, right? So you absolutely need that direct visual of the urethra and bladder. And a quick clinical pearl, if gross hematuria keeps coming back, you repeat this entire 3-step workup annually. Okay, let's dive into this table. This is the Bosniak classification system for renal cystic masses. Fun fact, 50% of people over 50 have renal cysts. And yeah, most are totally benign. But you have to know how to risk stratify them using CT, MRI, or ultrasound. Look closely at how we stage these, from 1 to 4. We're looking at septations, thickness, and, this is the big one, enhancement. Let's distill that down to the high-yield stuff you actually need to memorize. Categories I and II, essentially benign. We're talking simple thin septa with 0 enhancement, no intervention needed. Category 3IF, and think F for follow-up, these have multiple thin septa and a sneaky 15 to 25% malignancy risk, so we just keep an eye on them, surveilling every 6 to 12 months. Now here is where you really need to pay attention, the massive jump at Category 3. The second you see measurable enhancement or soft tissue, meaning categories 3 and 4, that malignancy risk skyrockets up to 92.5%. Your management flips instantly from let's watch it to we need to surgically resect or ablate right now.
Shifting gears from cysts to solid renal masses. Keep in mind, 80% of these solid masses are malignant. And a line between doing partial versus a radical nephrectomy, it's incredibly strict. For T1 and T2 lesions, those are the ones 10 centimeters or less and totally limited to the kidney, we prefer a nephron-sparing partial nephrectomy. But once you hit T3 and T4, where the tumor is literally extending into major veins like the vena cava or busting beyond Gerota's fascia, a radical nephrectomy is absolutely mandated. Also, keep your radar up for paraneoplastic syndromes. They pop up in 10 to 40% of these cases. The tumor might pump out renin, causing hypertension, or PTHRP, triggering hypercalcemia. It could even cause Stauffer syndrome, which is this wild, benign elevation of liver enzymes that just magically resolves once you take the tumor out.
Moving on down the tract, Section 2, Ureter and Bladder Pathologies. For urolithiasis, ureter stones, here is your acute game plan. Step 1, diagnosis. Grab a non-contrast CT. It's your most accurate tool, boasting over 88% sensitivity. Step 2 is medical expulsive therapy. If the stone is under 10 millimeters, start them on a daily alpha blocker like tamsulosin. This actually boosts spontaneous passage rates by up to 20%. Hook them up with some narcotics for the pain and make sure they strain their urine. Finally, Step 3, surgery. If they're stuck in pain for 2 to 3 weeks, have acute kidney injury, bilateral obstruction, or the stone just won't budge, you've got to escalate. We're talking shockwave lithotripsy, ureteroscopy, or percutaneous nephelothotomy for the really tough cases.
All right, down to the bladder. Remember how we talked about microscopic hematuria earlier? Well, up to 5% of those patients actually have bladder cancer. And urothelial cell carcinoma, or UCC, makes up over 90% of these tumors in the US. Let's rapid-fire the risk factors. The absolute strongest link, smoking, hands down. But you also need to watch out for occupational exposure to textile dyes, past treatments with the chemo drug cyclophosphamide, chronic inflammation from stuff like indwelling catheters, and, this is a classic board question, chronic parasitic infection with schistosoma hematobium. So when you're evaluating urothelial cell carcinoma using the AJCC-TNM staging, you're looking for one critical anatomical dividing line. Take a look at the T stages here. The entire treatment pathway literally hinges on one question: has the tumor reached the muscularis propria? Let's simplify that staging into the actual clinical divide you'll use on the floor. If the tumor is superficial, meaning CIS, TA, or T1, it hasn't invaded the muscular wall yet. You treat this with a transurethral resection, or TUR. But watch out, because superficial tumors have a massive 40 to 80% recurrence rate in just the first year. That demands super diligent follow-up and intravesical therapy like BCG. Now, if it is muscle invasive, stage T2 and above, you are looking at major radical surgery. We're talking a radical cystoprostatectomy in males or an anterior excentration in females, followed by urinary diversion. Big, big difference in management. Okay, Section 3, prostatic diseases and management. The prostate is the site of the most common malignancy in American men and the second leading cause of cancer death. So here are the absolute essentials. For cancer screening, the AUA guidelines say you should be discussing a digital rectal exam and PSA screening with patients between ages 55 and 70 every 1 to 2 years. Now, for benign conditions like BPH, patients usually show up with a weak stream, urgency, or bladder outlet obstruction. But hey, pay close attention to this next part. It's a massive metabolic trap. Post-obstructive diuresis. If you acutely relieve a chronic urinary obstruction with a catheter, the patient can suddenly experience severe polyuria and natriuresis. If that dumps urine for more than 48 hours, it causes terrifying electrolyte derangements. You have to monitor their vitals and fluids like a hawk. For treating BPH, start medical with alpha blockers like timsulicin or 5-alpha reductase inhibitors. If that fails, the surgical gold standard is a TURP or green light vaporization.
Dropping down into the true emergencies. Section 4, penile and scrotal emergencies.
We need to clearly differentiate between ischemic and non-ischemic priapism, which is a persistent erection completely unrelated to sexual stimulation. The clinical differences you see here are exactly what will dictate your very next move in the ED.
You have got to vigorously separate these two in your mind. Ischemic priapism, that is a true drop-everything emergency, especially if it hits the 4-hour mark. It's a venous outflow problem, often triggered by sickle cell disease or medications. It's incredibly painful, the corpus are rigid, but the glans is flaccid. If you don't act fast, fibrosis sets in and causes permanent erectile dysfunction. First-line treatment is immediate corporal irrigation and aspiration with an 18-gauge needle, followed by a phenyline ephrine injection. Non-ischemic priapism, on the flip side, is not an emergency. It's an arterial inflow issue, usually from some kind of trauma. It doesn't hurt, it's only partially rigid, and honestly, most of these just resolve with simple observation.
All right, here are your absolute surgical red flags. First step, testicular torsion. The testicle rotates on its vascular pedicle, cutting off blood supply. The classic sign, an absent cremasteric reflex. Listen to me on this. This is a clinical diagnosis. Do not waste time waiting for an ultrasound if you suspect it. Treatment is immediate scrotal exploration and bilateral orchiopexy. Next is paraphimosis, where the foreskin gets trapped below the glans, causing massive swelling. You need to do an immediate manual reduction. Grip it firmly to squeeze out the edema and push the glans back in. Finally, Fournier gangrene. This is a truly terrifying necrotizing fasciitis of the perineum with a mortality rate pushing 30%. You need a CBC and cultures drawn instantly, blast them with broad-spectrum IV antibiotics, and get them to the OR for urgent, wide surgical debridement.
Let's hit a classic board exam buzzword, the blue dot sign. Imagine a patient comes in with mild testicular pain, but the testicle is in a normal position. You look closely and spot this visible, little pea-like blue nodule right through the scrotal skin on the superior side. That is torsion of the testicular appendage, not the testicle itself. The management distinction here is huge. You treat this conservatively with NSAIDs and scrotal support for a week or two. 0 surgery required.
Here's our second high-yield definition, the bag of worms. This is exactly what a varicocele feels like on a physical exam. It's basically abnormally dilated testicular veins that bulge out even more when the patient bears down or does a Valsalva maneuver. Now, they are the most common surgically correctable cause of male infertility, but most are actually asymptomatic. But here is the absolute golden rule. Right-sided varicoceles are exceedingly rare. If you feel that bag of worms on the right side, that is a huge red flag. It mandates immediate retroperitoneal imaging to rule out a compressive tumor.
Almost at the finish line. Section 5, Genitourinary Trauma Guidelines.
When we're dealing with renal trauma, we rely heavily on the AAST, the American Association for the Surgery of Trauma, grading system. We use this directly to decide who gets watched and who gets opened up.
Let's translate that complex grading scale into a fast, binary protocol for the trauma bay. Grades I through 3, those are your contusions, subcapsular hematomas, or lacerations that aren't leaking urine. For these, we observe strict bed rest, serial CBCs, and repeat scans. But grades 4 and 5, those are catastrophic. We're talking lacerations tearing through the collecting system, devascularized kidneys, or just a totally shattered organ. Those demand immediate action, either renal embolization by interventional radiology or straight to the OR for surgical exploration, and you're very likely looking at a nephrectomy.
Let's wrap up our trauma review with the urethra. Posterior urethral injuries, which involve the prostatic and membranous urethra, almost never happen in isolation. They're usually paired with brutal multi-organ or pelvic fractures. You need to suspect this instantly if you see blood at the meatus, feel a high-riding prostate on a rectal exam, or spot a massive hematoma creating the classic eggplant deformity. And here is the absolute golden rule. Do not, under any circumstances, try to routinely repair a posterior urethral injury in the acute setting. Early surgery leads to terrible rates of impotence, incontinence, and strictures. Put in a suprapubic catheter to drain the bladder, and plan for a delayed repair 3 to 6 months down the line.
All right, let's close out this explainer with a final scenario to test your synthesis. A trauma patient rolls in. You diagnose a grade V shattered kidney. You know you're heading straight to the OR for exploration. But as you assess their severe pelvic fractures, you spot a drop of blood at the meatus. Why must you immediately tackle anyone trying to place a standard Foley catheter? Because blindly pushing a catheter through a torn urethra can easily convert a partial tear into a complete transection. You have to get a retrograde urethrogram first. Master these rules and you will absolutely own urologic emergencies. But it really begs the ultimate surgical question. In the absolute chaos of a trauma bay, will your clinical judgment be sharp enough to know when to operate and, more importantly, when to stop someone else from making a catastrophic mistake?